A third eye in glaucoma surgeries. Real-time optical coherence tomography guided surgery. The OCT allows us to see beyond the resolution of the human eye and provides a structure-wise detail of ocular tissue. Intraoperative optical coherence tomography guided surgery would allow the surgeon a real-time cross-sectional view of the surgical field, especially when on-face visualization is not available. The utility of both anterior segment and posterior segment OCTs in both diagnosis and management of glaucoma is well established. These machines give both qualitative and quantitative information of the tissues of interest. The Zeiss Lumera microscope with the integrated Rescan 700 OCT ushers a new era of surgical practice. The specifications and details of the instruments used are shown in the image here. The real-time cross-sectional imaging while operating could be useful in various steps of both anterior and posterior segment surgeries. Imaging is done either with customized sizes of cube scans or with raster line scans. On the screen on the left side, we can see the live surgery being performed, and on the right side, cross-sectional real-time imaging of the areas of interest with the OCT. The right top box shows horizontal sections of the cube, while the bottom shows the vertical sections. The surgeon identifies the region of interest in the operating field where the cube is placed and then has to correlate this with the live imaging seen on the right of the screen. The OCT images are also projected into the surgeon's view of the operating field as a heads-up display without really interfering with surgery itself in any way. In the rest of the video, we will discuss various glaucoma procedures where the eye OCT can be helpful, including phacoemulsification with trabeculectomy, Ahmed valve implantation, goniosynovial lysis, and bleb needling. The two white arrows we see on the top right image show the incision made for creating the scleral flap. In cases where there is scleral pathology, this cross-sectional viewing of the tissue would be extremely helpful to get a precise depth of the cut. The red arrowhead shows the scleral flap being elevated and the corresponding gap is seen on the OCT image on top as demonstrated by the yellow circle. Here we see the surgeon making the corneal side port, and the right top end OCT image shows the corresponding uniplanar self-sealing nature of the side port incision. Now the keratome is inserted into the anterior chamber, and this is delineated on the OCT as a hyperreflective line. The main port triplanar incision can also be appreciated clearly. One of the limitations of OCT imaging is the shadowing effect due to the fact that the bandwidth and the wavelength of light used does not pass through instruments made of steel or titanium. Here we can see the surgical blade casting a shadow and blocking visualization of the underlying tissue. Instruments that would allow wavelengths of the light used by the OCT to pass through are being developed at present to overcome this issue. The surgeon then creates the internal ostium using the Kelly sponge. This is seen clearly in the respective OCT image. The stoma is well seen in this horizontal cut section on the OCT. After the entire stoma has been created, we can now see the part of the deeper sclera that has been removed in relation to the superficial scleral flap. Another potential application of this imaging tool could be during deep scleral flap dissection in non-penetrating glaucoma surgeries, where the precise depth of the dissection is mandatory to prevent it from becoming a full thickness procedure. This aids in obtaining precise trabecular descendants windows. And at the end of the surgery, we can see a diffuse bleb elevating after injection of saline through the side port. This eye underwent Ahmed valve implantation for intractable glaucoma following a failed penetrating keratoplasty. The OCT images show peripheral anterior synechiae at the graft-host junction. The red arrow in the top right OCT image shows the outer point of entry for the tube, while the red line across the lower image shows the plane of insertion of the tube. The two red circles in both the images demonstrate the tube well positioned in the anterior chamber. A critical step in Ahmed valve surgery is the positioning of the tube into the anterior chamber, which is essentially a blind procedure. OCT guidance could potentially help us obtain a desirable intrascleral passage and entry into the anterior chamber. In this part of the video, we highlight the utility of the IOCT in goniosynechial lysis. This was an eye with a history of acute angle closure that had developed 270 degrees of peripheral anterior synechiae and a visually significant cataract. Phagomulsification and goniosynechial lysis were performed. The red circle in the OCT image shows the peripheral anterior synechiae. Routine phagomulsification surgery was performed, and at the end of the procedure, goniosynechial lysis was done using a blunt spatula under direct intraoperative OCT guidance. At the end of the procedure, it is evident that the iris has fallen back and the peripheral anterior synechiae have been released. In this clip, we demonstrate the use of intraoperative OCT in bleb needling. Episcleral fibrosis is a common cause for the failing bleb with subsequent increase in intraocular pressure. In this eye with a failed bleb, episcleral fibrosis with lochulations can be seen intraoperatively using the OCT. The two oval circles show a large single hyporeflective cavity that has been created within the bleb following needling procedure. We would like to conclude by saying that the IOCT integrated surgical tool appears to have a promising role as an adjunct in glaucoma surgery. This adds an extra dimension for the surgeon and could potentially develop into a good teaching tool. Further improvements in resolution and development of surgical instruments that would allow unhindered visualization of the regions of interest might make this an indispensable tool in intraocular surgery.